Hi, friends. This is Dr. Ravi Kamepalli. I'm an infectious disease, wound care, and obesity medicine doctor. I am practicing in Georgia, USA, and it gives me a great pleasure. Um, and this is an extended presentation of the a short presentation that I will be giving at the New Dimensions in Diabetes conference that is being conducted in India on September 11th, 2021. And the topic given to me is role of obesity and I added diabetes in the infectious disease outcome. My target is the tsunami of chronic diseases, and my website is nobadbugs.com as I'm an infectious disease doctor. And also, I want to say that I don't have much of any conflicts of interest. And basically, I work on solutions for infections, wounds, and obesity, work on some telemedicine solutions. And I just have to say that I have some great goals, but I need to have great partnerships in making those goals come through. And my effort at this process is simple: work with people, help people, make things better. The learning objectives for today's discussion is we need to define the problem, understand the role of obesity and infection, and how metabolic health influences infection and infection influences metabolic health outcomes, understand the sugar effect on infection, obviously discuss the COVID and comorbidities that have effectively changed how we think about medicine. But I have been trying to convey this lecture since around 2016 and 17. I've lectured on this topic, but obviously the current pandemic kind of bolstered my thinking on this process. We're going to talk a little bit about personalized nutritional lifestyle that I promote for my patients. Defining obesity is defined as a chronic, relapsing, multifactorial neurobehavioral disease wherein there is increase in body fat, the promoting adipose tissue dysfunction, and abnormal fast mass physical forces resulting in adverse metabolic, biochemical, and psychosocial health consequences. To shorten it up, it is nothing but a fat mass disease because of hormonal disorder. This was recognized after a long time in a AMA in around 2013 June, when I was kind of thinking I was at the peak of my infectious disease and wound care career, but I was kind of working on helping the wheel of my office being a repeat visitors of my patients who ended up getting treated, but the revolving door of office continued. And but at that point, I came across this one of the T-shirts one of my patients was wearing, saying that we are all infected, and that prompted me to come up with my website, nobadbugs.com. And I was trying to understand why bugs or bacteria, viruses, and parasites are there. Are they our foes, or are they there to help us? Obviously, I think they are there for a purpose, and we have to live in symbiosis with them. But sometimes when things go bad, we become obese, have metabolic problem. But I do care about obesity because it's a complex chronic disease affecting more than 650 to 800 million people worldwide. And there is a impact of obesity that affects almost going to cost us more than $1 trillion. And more than that, for me personally, it affects most of my patients who suffer from infections, wounds, and metabolic health complications. And we have to take responsibility. We have to move medicine from the end game of medicine that we play, like this patient that lost a toe. But then I'm trying to help him improve his metabolic health to save the foot. So the question just comes down to understanding the decades of problems that we faced before. We called it decades of disaster, decades of disease, and decades of decay. 2009. was the flipping point of my understanding of what is going on in healthcare. I tried to start a wound center in India in 2008, and this paper came out in 2009. WHO stating that non-communicable disease such as heart disease, stroke, and cancer, and diabetes and lung disease are responsible for 35 million deaths, or that is 60% of deaths worldwide. So that means that more deaths are occurring in now because of diseases of decay. So now the decades of decay or diseases is happening. So in the past, when people used to die, it was because of disasters or it was because of infectious diseases. But now we have entered into a state of wherein underlying basic metabolic health problems do influence how infectious disease outcomes happen. And you have to understand that chronic diseases, if you take America, and data is mostly available from America, so I have to quote that, and 6 in 10 people have chronic diseases, and 4 in 10 have two or more of them, causing around 3 point, causing a leading cause of healthcare total cost of 3.5. Now it has gone to 3.8 or $4 trillion around that number. But as you can see here, the really tobacco, poor nutrition, lack of physical activity, and alcohol use lead to major problems. And obviously, it just comes down to lifestyle disease factors that decide on how the chronic diseases happen. And obviously, 3 in 4 of the deaths are attributable to chronic diseases. And obviously, diabetes, obesity, heart disease, cancer, and stroke contribute to this. And you can see Alzheimer's is catching up. And obviously, there's other chronic issues, including complications, including inflammation and arthritis. But we have to understand that 70% of the chronic diseases are associated with unhealthy lifestyle per CDC. And also, you have to understand that 60%, as per this RAND study in 2017, showing that basically 60% of Americans are living with chronic disease, 42% of Americans are living with two or more chronic disease. But this is another eye-opener study that was done, a prevalence study that showed in 2016, I think it came out, it's showing that there is alarmingly low normal weight individuals in the country in US, and obviously 12% prevalence corresponding to 27.3 million adults with optimal metabolic. So basically, there is 12% of Americans are metabolically healthy, and rest of them, that is 88%, are not metabolically healthy. And dietary guidelines unfortunately focus on metabolically healthy patients, but in reality, that dietary guidelines are being applied to the 88% of people. And that is a very sad state of population health, where the nutritional guidance in this nation is one size fits all, whereas that's not the truth in healthcare, where one size never fits all. But we try to kind of ram a round peg into a square hole, or whatever it is they. So it just comes down to understanding about obesity, why and how obesity is diagnosed, and what is going on with trying to understand this obesity is defining it. And the problem also starts with the way in which it was defined with BMI. Its BMI is a crude marker, but in reality, this has to be defined by percent body fat, by all the different advanced testings. Simple bioimpedance testing that could be in any doctor's office is a start. But if that is a problem, simple waist to height ratio, a tape measure, could throw in a change. If you start measuring a waist to height ratio and targeting and teaching patients to improve their waist circumference by whatever methods you can teach them, that would be obviously a great start. Obviously, there's other issues that could be administered obesity staging, wherein initially the obesity is subclinical, stage 1, whereas when they start having moderate functional limitations is stage 2, end organ damage is stage 3, but severe disability is stage 4. Now, problem comes down to Asians. Asian heritage is a huge issue. That is, they are mostly thin on the outside, fat on the inside. And if you see, the 23 is the cutoff. I think even in US there is a 23 for Asian genetic heritage is obviously the cutoff marker wherein they can be screened for problems associated with obesity at the BMI of 23. Whereas we wait until it goes to 30 or 31 before even thinking about that. Complex interactions happen in obesity because of all the issues that are associated. Human beings were thin, were hunter gatherers, and obviously something changed in the last 3 to 400 years. But over time, nutrition, we got good at agriculture, and the nutritional methodologies change, processing change, how we eat change. Obviously, the viruses are environmental suppression, and we have to understand that what changed apart from the process is that we are endowed with survival. We have hormones that influence how we think about what we eat, how we get addicted. So basically, obesity, I believe, is a hormonal disorder of fat metabolism. Obviously, there is a lot of other factors, psychology being a huge factor, and obviously social status, lack of exercise, nutritional lifestyle is a huge thing. This was a quote from Guyton from 2006 textbook of physiology. It becomes apparent that insulin secretion is associated with energy abundance. A great abundance of carbohydrate and insulin in the presence of great abundance of carbohydrates, insulin is secreted in great quantities. So the excess of carbohydrates are converted under stimulus of insulin into fat, and that is stored as adipose tissue. Why that becomes significant is because we are hormonally and genetically driven human beings who have been functionally modified because of the hormones. Uniquely, each one are affected differently. That is heterogeneously expressing in each one of us differently. So we have to understand that we have three macronutrients mostly, apart if we take off vitamins, and carbohydrates, protein, and fat affect the blood sugar differently. Carbohydrate, if it's 100%, blood sugar response, protein is 40, and fat is 5% or maximum 4 to 5%. So, but the problem is that as we stimulate insulin over time, the fasting sugar is controlled, but there comes a point there when there is increased resistance. Obviously, during this trend, there is a pre-diabetes or pre-diabetes when metabolic dysregulation is happening. That is, atherogenic happens because of glycemic variability. That's a very important word, and that is an important topic that has to be discussed down the road. Something called as glycemic variability, not for discussion today, but obviously, the more the insulin resistance, there is less beta cell mass, and that leads to diabetes and underlying complication that also cause from obesity, which you can see 30 or more conditions are associated with it, with most of them related to cardio, metabolic, and basically severe issues with arthritis, skin problems, gout, cancer, multiple 13 cancers, which I will show later, and also issues with stroke, cataracts, pulmonary problems, and non-alcoholic fatty liver is one of the real problems that we are facing. We have to understand why, because we think that thin people, just because they are thin, are not obese, but that is not the view. We have to have an inclusive view of obesity and metabolic dysfunction, wherein we have to understand, if we take US as an example, 240 million adults in US, and of them 168 people are noted to be normal weight, but 72 million are obese, whereas this 30% of them are obese, and 32, I guess it has gone up to 40 now, but just take this number. Dr. Robert Lustig was the curator for this data, and obviously you can see that even in obese people, there are people. There's people that are not sick, but in normal weight, there is metabolic dysfunction. So obviously, there's 124 million people that are sick. Now we need to understand that this kind of skews and makes us not focus on the real cause of the pathogenesis, and understanding that the current state of knowledge is not great. Uh, we don't look at metabolic syndrome, number one. We look at disease as a silos. We treat silo medicine, but we don't connect them. Whereas we need to approach this in a whole person approach, not whole in a person that I talk about when wound care. But we have to understand that metabolic signaling in different tissue is different. This is a complex metabolic pathways that happen, and obviously it's different in different areas. In the liver, it could be different. It could be different in the gut. It could be different in the brain and pancreas. But the sad state of healthcare is we do standard deviation medicine. We take all the people, we put them together, we do a population study, and say that just because it is a drug is applied in this standard deviation of two standard deviations, then what happens to the one third of the populations that are out of the standard deviation? What if that is you and me? What if that is somebody that is suffering? What if we don't give them the right approach and knowledge and guidance? That's where the healthcare is failing. And obviously, sugar is a real culprit on this, and sugar affects infection, because we have to understand that increased sugar intake reduces the resistance to infection. Fasting helps prevent infection because it helps phagocytosis. In this article that I'm going to show later, we see that approximately the sugar effect on neutrophils take approximately at 2 hours it start, but it lasts until 5 hours. And obviously, we have to understand that natural killer cells, which are immune cells, are affected by glycation process with methyl glyoxal that is formed, and obviously that conjugate formation prevents the work of killing the tumor cells by natural killer cells. And obviously, glycation of the tumor cells also interferes with the natural killer cell function. And this article of role of sugar in neutrophilic phagocytosis is very important, wherein carbohydrates are shown to effectively cause trouble, whereas the phagocytic index, meaning the bacteria viewed within the neutrophils after sugar intake, are significantly reduced, and the greater effect is between 1 to 2 hours and lasting for 5 hours. So basically, fasting for 36 hours to 68 hours improves this phagocytic index. So phagocytosis is very, very important for understanding the process of how this neutrophils function, and fasting helps with that. I want to share a quick video, if I can, and I'll try to push through it and try to show this, because number one, we have to understand how neutrophils
Leukocytes
function.
are white blood cells that help fight infection. At sites of injury, infection, or inflammation, cytokines are released and stimulate endothelial cells that line adjacent blood vessels. The endothelial cells then express surface proteins called selectins. Selectins bind to carbohydrates displayed on the membrane of the leukocytes, causing them to stick to the walls of the blood vessels. This binding interaction is of sufficiently low affinity that the leukocytes can literally roll along the vessel walls in search for points to exit the vessel. There, they adhere tightly and squeeze between endothelial cells without disrupting the vessel walls, then crawl out of the blood vessel into the adjacent connective tissue. Here, leukocyte rolling is observed directly in an anesthetized mouse. The up and down movement of the frame is due to the mouse's breathing. 2 blood vessels are shown. The upper one is an artery with blood flowing from right to left. The lower one is a vein with blood flowing from left to right. Leukocytes only adhere to the surface of veins. They do not crawl out of arteries. Some leukocytes are firmly attached and are in the process of crawling through the vessel walls, whereas others have already left the vessel and are seen in the surrounding connective tissue. When the blood flow is stopped temporarily by gently clamping the vessels, we can appreciate how densely both vessels are filled with red blood cells. Red blood cells do flow that we cannot see them. All non-interacting cells are immediately
So this is the animation from that. I need to thank them and Molecular Biology and Cell 4th edition. But
Leukocytes are
so
white blood cells that help fight
we'll go to the
infection.
next video, which is a neutrophil chase video that
Neutrophils are white
fastly
blood
push
cells
through.
that hunt and kill bacteria. In this spread, a neutrophil is seen in the midst of red blood cells. A Staphylococcus aureus bacterium has been added. The bacterium releases a chemoattractant that is sensed by the neutrophil. The neutrophil becomes polarized and starts chasing the bacterium. The bacterium, bounced around by thermal energy, moves in a random path, seeming to avoid its predator. Eventually, the neutrophil catches up with the bacterium and engulfs it by phagocytosis.
This is the same again, thanking them. Basically,
Neutrophils are
so basically, what I want to stress is how blood sugar can cause problems with those mechanisms that you just saw. And obviously, glucose is a rigid planar molecule, and when it's in the blood, it damages the nerves. And this article, you're able to see that obviously diabetes and is caused by all the platelet problems, inflammation, endothelial dysfunction, and smooth muscle problems, and these ends up causing atherogenesis and peripheral vascular disease. Vascular disease is the root cause of all the problems in chronic disease. Endothelial dysfunction happens, but we have to understand that glycation causes the end products of glycation, and it is worse when it is with fructose. If you see, fructose causes times 7 glycation, and even the red blood cells get clogged up like this. We have to understand that glucose increases the problems of inflammation through a complex process, and autoimmunity exacerbates because of high glucose intake. If you see this experimental mice study, it's shown that the Th17 pathway, which is an inflammatory pathway, is very much affected by glucose intake. And obviously, this changes the T cells, and high glucose increases the mitochondrial release of reactive oxygen species in the high glucose environment. Obviously, that acts through the TGF beta activation, and Th17 cells are very much important. I will mention this before the end again. Remember, the Th17 cells as an important aspect of the pathway of immune system that causes a lot of problems with inflammation and infection. So COVID-19 and obesity. COVID has taught us a little bit, so we have to thank that guru who has taught us. Maybe we are not behaving as a human race, and maybe that was a really a tough guru. And I don't know if I need to thank or not thank, but I guess we don't have any other option. We have to learn from our mistakes. And obviously, obesity is an important associated factor in this COVID because of dysregulated fatty acid mechanisms, elevated stress, hypoxia, and increased pro-inflammation. Defective immune system is very huge because in somebody with obesity, obviously there is increased vulnerability because they are not able to mount an immune response that obviously helps with initially effectively fighting the SARS-CoV. And there is increased cytokine results here, and adipose tissue, adipokines are generated that are favorable for the disease. And obviously, this dendritic cells cannot function. The dendritic cells and immune cells cannot function, and that leads to severe disease and poor outcome because of chronic inflammation and obesity and ACE2 expression that is increased in obese subjects with COVID-19 infections. You can see here that 40% are obese in US, and obese people are more likely to get admitted to the hospital and have outcomes that are worse. Whereas we are told to take vaccines, which I really want to promote. And I was one of the first guy taking the vaccine. But also I was the first guy saying that immune system has to improve. We are not learning from our mistake, and different variants of the viruses are coming back at us. So hopefully we learn this time around. But these 10 factors, apart from age, are noted to be very important for risk factors for infectious disease outcomes: obesity, metabolic health, diabetes, hypertension, heart disease, autoimmune conditions, cancer, impaired immune system, obviously prolonged exposure to COVID with high viral load. There is an opinion piece that we wrote in 2020 early, that was published in University of Louisville Respiratory Medicine Journal, where I talk about disease triangle concept. But when it comes to SARS-CoV, there are other factors that influence, which include metabolic factors, which are hyperinsulinemia, hyperlipidemia, and nutrient dysregulation that causes metabolic dysregulation of T cells. And obviously, we have to understand that the viral factors are very much important, no doubt, but we are focusing on the bacteria or the fungus or the virus of the day. But we are forgetting to understand that it is depending upon how much the virus we're getting, what is the load of virus. Masks will prevent if we wear like a good mask. That prevents the viral infection. But obviously, the individual's immune system, lymphocytes are very much needed. Basically, neutrophil lymphocyte ratio is very important, and physical status and nutritional status, and interaction of these viral factors and individual's immune system becomes very important as to how the non-communicable disease outcomes affect. When it comes to diabetes, there is amplification of ACE2 receptors. Obviously, reduction of these receptors can happen as soon as the glucose control is improved, and that is very important. Whereas there is reduced vascular perfusion and tissue health, and when the people can get glycation and atherosclerosis, and an increased fatty acid oxidation and insulin resistance can happen. And there is immune system dysregulation when there is increased acidic environment. There is cells that bind to endothelium and increased Th17 cells, which we talked about. And in this science review that was published, basically it showed that diabetes is a primary risk factor. And this was also shown in MERS, that when it happened, that diabetes was significant risk factor. When with SARS-CoV-2, there was CDC saying that there's 50% higher risk of fatal outcomes in SARS-CoV-2. So basic understanding is, why does this happen? I came across a paper just like 4 or 5 days ago, which showed that viral insulin-like growth factors like peptides are structurally similar and have significant homology to insulin-like growth factors, viral insulin-like peptides. And they have almost shown to have 50% homology to human insulin-like growth factors. That shows that increases glucose uptake in fat cells, stimulate the fibroblasts, and obviously that presence of these kind of viral particles has been noted to modify how human health and disease changes happen. That shows that insulin-like growth factors are very important, and obviously glucose plays a huge role. We have to understand that in the schema of different ways in which SARS-CoV affects, there are multiple checkpoints which we can do: convalescent sera, we can do different anti-inflammatory methods of working Obviously, different viral mechanisms are there, antiviral medications we're trying, but it just comes down to how an immune response, immunomodulatory therapies, okay, can control the inflammation, how one's interferon response is, how the natural killer cells are, how the IL-6 pathway can be stabilized. I particularly brought this drug into this picture, into this slide, is because uh, the viral antiviral effects can have be used at different levels, at replication, at inflammation level, but to organ protection. Does SGLT2 have the same one like all the immune suppressant, cell protection or monoclonal antibodies have? Does drugs like SGLT2 have a effect? I believe they do, but then that has to be proven. But if you look at it, we understand that endothelial function is reduced in COVID-19, but endothelial function improves with SGLT2. There is reduced inflammation, there is reduced glycolysis. But how does this happen? That is a kicker in this whole process. People are needing to understand that there is a significant side effect that is promoted as a side effect for SGLT2, and that side effect is basically might be the point where we might be able to help use this drug. I've never used it, but in this aspect. But I want to tell you that they talk about this keto acidosis that can happen with this drug. But obviously, ketones are noted to be anti-inflammatory, and that might be how this drug affects possibly the anti-inflammatory and organ protective effect that is kind of being thought of per this Journal of Clinical Medicine article that I came across. So glucose it plays a significant role in the innate mechanism in the alveolar level mucosal periciliary area epithelium. Then basically the functioning of the epithelium is affected because of increased glucose causing increased viral replication, obviously causing inflammation and vasoconstriction, which is very much what happens with SARS. And obviously, this is something which has to be looked at closely because in the perfect storm of uh, obesity and the metabolic health problem, a syndemic of metabolic health is causing the bad outcomes with COVID. And how does this happen? Is simply, as I stated earlier, obesity is a fat mass disease wherein there is increased chronic inflammation, there is immunocompromise, and obviously this happens when the body fat mass, like remember I told you it's a fat mass disease, wherein in a male, if a fat mass goes more than 14 to 20%, I think if we have trouble. Females more than 28%, there is more problems. Why does this problem happen? Is because the poor T cells can get sequestered away into this whole metabolically dysregulated, compromised fat where there is more inflammation. So the T cells get stuck, and obviously there is inflammation that is happening, and the inflammation increases when the COVID comes into that picture too. So if you can see here, this is a non-hospitalized individual and chronic hospitalized and non-hospitalized individual cases. If you see in this COVID-net surveillance study, the hospitalized patients uh, are increased in patients who have diabetes, hypertension, and obesity. That itself tells us that there is a significant metabolic health influence. So our priority, apart from masks and vaccines, has also to be improve the metabolic health of our population. Multiple studies have shown that this triumvirate way hypertension, obesity, and diabetes risk is a huge factor in adverse outcomes of COVID. And another study showing that serum levels of SARS-CoV-2 antibodies are reduced in people with obesity, and obviously adipocyte inflammation and pathogenesis is increased in people having viral pneumonias. And obesity and respiratory infections obviously can be having worse outcomes because of all the cytokines that are produced, lipotoxicity and defective innate immunity, and increased susceptibility for nosocomial infections and susceptibility from viral infections like influenza or COVID. Um, it is widely recognized that hypertension, diabetes are associated with more severe COVID outcomes. When it comes to understanding these multiple papers have shown that multiple pathways are affected. How does this happen? Is with excess obesity and ectopic fat, there is cardiorespiratory reserve is reduced, lung function go down, cardiovascular susceptibility for vascular effects are increased, as we see with increased thrombosis, but immune dysfunction happens. There is increased viral problems with viral exposure, and obviously increased severity. Now, we can continue to say that, but we have to understand that pandemics do happen. Now it is COVID. In the past, it was influenza. There was there is other pandemics that happen. Pandemics is the nature way of working, and our system is 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 evolved to survive, and we cannot go and try to think that there is going to be another virus and we'll wait for another vaccine. But it's a reminder. I think COVID is a reminder for us that infectious disease is complex, it is multi-system. We need a holistic response to this whole process. And unless the societies that are working at it, not from a drug-centric standpoint, we also have to understand that there's a human being and human beings have evolved, and we have to understand that the critical nature of this understanding, and understanding how immune system can be augmented, how we can take this process of chronic inflammation that happens, or slow grade inflammation that is happening in obesity, and how our system can improve from the vascular damage. And we can come up with the 4 different strategies that were stated in this Nature article that say avoidance by metabolic consequences, improving insulin resistance, and also working towards improving the resistance via decreasing glycolysis that happens, and obviously antivirulence by understanding the glucose flow and interferon response, and disease tolerance by preventing things like muscle wasting and processes that are obviously showing that glucose increase is causing more trouble than most other things. And we have to understand that that is being shown even in influenza, wherein there is increased influenza viral impact when the viral load that is shedding is more in obese patients than in non-obese patients. So coming down to even bacterial virulence, we have to understand that there is something called as quorum sensing, where multiple bacteria come together and produce something called as lipopolysaccharide or lipoteichoic acid, which is causing the inflammation and all the consequences of endotoxemia. And then the body's good lipid particle, lipoprotein, LDL, which is kind of blamed as a bad particle, and we give cholesterol medications for it. In fact, it is a policeman of the system that goes and tries to work against this problems that are associated with increased lipopolysaccharides. And basically, bacterial virulence is taken care of because of our lipopolysaccharides appropriately responding. When our metabolic system is better, we have an appropriate LDL response that takes care of it. We'll quickly go through how obesity impacts the outcome of infectious disease, but we have to understand that this is a prelude to this whole sequence of discussions, but we'll go through quick studies that have shown that. Uh, but one study that goes against the thinking is something that has shown that there is something called as obesity paradox, wherein it talks about how there is a metabolic reserve. But the problem with this study is it was a single center study, and this was a study done by Atman et al. That was kind of a single center collection bias study with a retrospective study. And obviously, that kind of goes against the norms of understanding. And basically, we have to also understand that there's multiple other studies that are disproving that idea. Um, when it comes to bacteremia in obesity, antimicrobial therapy, bacteremia in outcomes in obesity, patients are worse in the Hunt study, and and another study where fat is very much shown to be a problem is visceral adiposity in patients who are treated with HIV, treated for HIV, and in C. diff infections, there is also obesity linkage for severe C. diff occurrence. So it comes down to surgical aspects. There's significant problems with associated outcomes with CABG in people who have BMI more than 40, and also patients who are having at least 20 to 50% higher odds of infection when surgical site infection with colorectal surgery. And bacteremia outcomes are noted to be worse with patients who have obesity, and a multi-center study that showed that as a problem with bloodstream infections when people are obese. So when it comes to even malaria, it is shown that obesity has worse outcomes, and in people who have diabetes and obesity. So this study is a C. diff study where BMI of more than 35 has shown 1.7-fold higher risk of C. diff cell infection outcomes. And obviously, we talked about the antiretroviral therapy causing visceral fat accumulation that is causing the trouble. So body mass index is a huge thing, but we have to understand that nutrition is a huge thing, because at the extremes of undernutrition or overnutrition, the infectious disease outcomes are going to be very bad. And obviously, we can continue to discuss further, but we need to understand that infection, the viruses do influence the obesity occurrence too, like adenovirus 36. And also I showed another study earlier regarding the insulin-like growth factors, some viruses causing them too. But adenovirus 36 is noted to show causing obesity in animals by increasing glucose uptake through the PI3K signaling, and there is increased glucose uptake and lipid accumulation happening. So multiple fat metabolisms are influenced by infection. Basically, lipids are there to protect us, but too much lipids, too much accumulation of fat causes more trouble. We can see that inflammation is increased as a consequence, and there is increased plasma triglycerides from increased VLDL secretion. And obviously, elevated triglycerides as well as increased glycerol and free fatty acid turnover is caused from body lipolysis. But another molecule that is very important is LP-little-a, which is noted in wounded tissue. And obviously, LP-little-a has a history, which is an LDL molecule with a tail to it, and it is increased. And obviously, it is being implicated in atherosclerosis and cardiovascular disease, and also some brain aneurysms. That's one of my interests because of my own personal history. So, family history. And let's go back to hyperinsulinemia, which is where I want to focus on. This is where a very crux of this whole discussion is coming down to, understanding that hyperinsulinemia has a consequence. COVID is a straw on this camel's back. It's just taking advantage of the problems that we are already suffering with metabolic complications, including metabolic syndrome, diabetes, and the iceberg effect of all these complications that are proving inside with fatty liver, cancer, Alzheimer's, dental problems. And obviously, the root cause is what we are not addressing. The root cause is the food that we eat. The complications are nothing but the branches of the tree. We are targeting those, we are not targeting the root cause. Maybe we should do that. And we have to understand that carbohydrate plus insulin is a huge problem. It's a dangerous combination. And insulin is released, and continued insulin release causes more trouble, making us less sensitive as we eat more carbs. And the progression of diabetes happens. Diabetes causes elevated is because of elevated sugar caused by carbohydrate intolerance. Maybe we should name diabetes as carbohydrate intolerance disease. But this problem can happen in people even if they are not obese. There is something called as sick fat, safe fat. I mean, that is something that we have to understand also, that this whole process is metabolic, and it has an influence how infectious disease outcomes happen, wherein the bacteria can invade the colon lining, and the colon lining then increases the lipopolysaccharide response, and a macrophage activity happens. There is increased free fatty changes, increased inflammation. Now, how do we effectively change it is by understanding that there is a body's innate ability to produce its own protection mechanism, but we have to understand and help it do that. And the way to do that is very low carbohydrate, a therapeutic carbohydrate restrictive process, wherein we can harness our own T cells, improve the nutrition by effectively changing this in a matter of 3 weeks. We can effectively increase our T cell function, ketogenic therapeutic carbohydrate restriction through an approach of what I call is as nutritional ketosis, which has been studied for prolonged times. There are multiple studies out there available. If anybody is interested, they can go to public health collaboration website in UK, and there's a lot of studies available. If you want to seek the knowledge, it's out there. We have to understand that this improves the T cell function, and this improves the way in which our immune capacity improves, and our memory cell function improves, and human CD4, CD8 response increases, and obviously the mitochondrial mass improves, and oxidative phosphorylation capacity changes. There is controlled reactive oxygen species formation, and obviously immunometabolic basis for enhanced T cell immunity is also there. So this was the paper that we had published in early 2020, wherein we talked about a greater outcomes with COVID as an opinion piece that was published in University of Louisville Respiratory Medicine Journal, that showed with evidence and peer-reviewed evidence that patients affected by influenzas have bad outcomes with comorbid diseases, and also T cell response influences how influenza outcome comes. But basically, what we opined is the success or failure of antiviral response will depend upon cellular metabolism, and particularly in 2019 September, there was one very effective article that made me think about T cells. It's from a mice study that was showing that influenza does not affect the mice when they are placed on a ketogenic nutrition, wherein the gamma delta T cells are kind of required, and they provide the protective effect by that approach. Now, we have this innate immunity, all these dendritic cells, macrophages, natural killer cells, and neutrophils and granulocytes basically working through gamma delta T cells. But we have to change and have to be able to improve the T cell response and push this into the B cell response, wherein we can produce the antibodies and long-term memory that takes to it. But we have to understand that inflammation is there already, baseline inflammation. How to control the baseline inflammation, reduce the fat mass, and produce protective mechanisms that we have inherently inside of us. How can we do that? Is by improving our metabolic health. We have some molecules called ketones. Ketone bodies are acetone, acetoacetate, and beta hydroxybutyrate. Beta hydroxybutyrate is noted to show improved oxidative suppression by endogenously producing by affecting something called as histone deacetylase inhibitors. So HDAC, histone deacetylase inhibitors, are what is used even in cancer. So obviously, these two studies have convinced me to think that inflammation is where we have to target if we have to improve inflammatory or chronic disease aspects of our health. NLRP inflammasome is suppressed by the ketones. This has a huge effect on how inflammatory diseases are going to be effectively be improved if somebody wants to help themselves. But as a medical and healthcare profession, we have to understand it ourselves so that we can help execute it in a low drug centric, patient centric, but a process centric approach. How to do that is simple, and investing and understanding time and investigating ketone bodies as a countermeasure against respiratory infections that help with reducing oxidative stress, neuroprotective effect, and obviously acting against the HDAC and all these complex mechanisms wherein the viral replication is effectively suppressed. And this huge potential, multiple studies out there looking at the therapeutic benefit of ketogenic nutrition. When I say ketogenic, please don't be worried. We're not talking about ketoacidosis. We're talking about nutritional ketosis, where the ketone levels are between zero point 0.5 to 3 millimoles per deciliter. And when the ketone numbers go beyond 10 is when you have the thought process of ketoacidosis. And that happens in people only when they are not able to produce insulin. So we have more problem of having more insulin causing insulin resistance. But coming back to this, we have to understand that there is potential benefits of ketogenic nutrition, including effectively reversing diabetes. Weight loss is a side effect of appropriate nutritional lifestyle, obviously helping improvement of cardiac parameters, atherogenic dyslipidemia, triglycerides to HDL ratio improved, and obviously microbiome changes. The bacteroides is increased when compared to Firmicutes batch of microbes. And that's very important. Cancer is a huge thing. And if you don't understand this impact and understand how we can take a multifactorial approach, you use chemotherapy, radiation therapy to kill the cancer cells, and use a therapeutic carbohydrate nutrition to help help the regular cells survive, whereas the cancer cells don't, through what the Warburg effect. So there's a huge understanding and cancer mechanisms that are being looked at for this. There is suggested other mechanisms, including strong evidence that is there now for diabetes, cardiovascular parameters, weight reduction, and epilepsy. There's other areas, including PCOS, cancer, that are being developed. Obviously, we have to understand that microbiome has a huge impact on how our bacteria can translocate from the gut into the blood vessels through changes in the tight junctions that happen when there is hyperglycemia. And obviously, good fiber intake is very much needed, but this has to be good fiber that has dietary flavonoids. But obviously, we have to also understand that the diurnal activity is very important, with the sun influencing how we change, and microbes. There's significant interaction there, which we don't understand completely. But obviously, we are seeing effective changes if people are able to stick to the diurnal variation, showing that last of evidence in patients who are night shift workers. So basically, also we have to understand that in age, there is different changes in obesity as we age. And obviously the bacteria increase in bacteroides is very much important. And we have to understand that there is significant issues that have to be taken care of for prevention of microbiome changes. When we effectively give antibiotic therapy, we are effectively changing microbiome. So we have to go towards minimalistic changes that effectively prevent microbiome changes for long term. So endotoxemia is very huge in infectious disease, but we have to understand that having a good microbial milieu helps prevent this endotoxemia. Low endotoxin absorption happens when we are able to metabolically be at the best state of metabolic health. And endotoxin influences can happen through these complex pathways. Low endotoxin absorption means our lifestyle is good. High endotoxin absorption means it is not good. This serious endotoxemia changes can happen when our innate immune system is kind of not good. So endotoxin rapidly induces lipid changes in the metabolism that produce high triglycerides. Low doses stimulate hepatic triglyceride production, and high doses inhibit the clearance of these triglyceride problems and endotoxemia issues. And experimentally, they have shown that endotoxemia can cause adipose inflammation and insulin resistance. Obviously, this is very huge when it comes to this, because they have studies shown that injecting lipopolysaccharides induces insulin resistance. This is what exactly happens with sepsis too. There is increased insulin resistance. So septic patients get all the infusions with glucose, all they get a TPN that has vegetable oils. That is very bad. So there is a whole complex problems that we are not addressing the right way. Obviously, cancer, the reason I like to look at this is because people is unnecessary suffering with cancer that is nutritionally being affected, because this is a CDC picture that shows that 13 cancers: breast, kidney, uterus, ovary, stomach, pancreas particularly is very much influenced by the microbiome changes. Obviously, meningeal brain-related issues are metabolically influenced, and one of them is glioblastoma multiforme, that has significantly correlation with nutritional outcomes that have been studied, and there is significant case series that have been done with GBM as an influence from cancer and nutrition. There is a reason why I'm talking about cancer and nutrition. I will tell you in a bit, but there is obviously significant correlation between cancer and caloric intake through some significant pathway called mTOR pathway, which is what mTOR drugs for mTOR pathway are being used for cancer treatment. But also we have to understand that there is this recent paper has shown, it's a prospective Nutrinet study, I think was done in France, that showed that there is significant impact on glycemic index, and glycemic load on cancer outcomes at a population level, and that has to be used. The reason also why I talk about cancer and infectious disease is I believe that these are both ends of one of too much growth, one of less growth. Obviously, when you see cancer and early infection and early neoplasia, there is reactive oxygen species. There is increased neutrophil and macrophage action. Obviously, as this happens, there is T cells that ultimately are exhausted, and obviously there is increased toll-like receptors or nod-like receptors, and this ends up causing significant changes with obviously in infection. If you develop biofilm, if the infectious disease wound bed or develops biofilms, then that causes persistence in the deep end. Similarly, the cancer has that whole thing. So I think cancer and infection are parallels, and this is something that the immunotypes of cancers and infections have to be studied. And obviously, we have to look at this very closely. From a CDC's perspective, they have shown this energy balance model, but obviously, I do understand this. It is wide spectrum, but what is lacking is when and how we can empower the individual factors of addiction model. That is very much important. It's more than energy. It is hormonal, how we can personalize the solution for one person at a time, include and create this people, process, and technology, come up with clinical treatment modalities. We have guidelines, but I have to stress guidelines are guideposts, they are not gospel. This has to be an understanding. Then we have to come away from mass medicine mindset. We have to help people develop self-directed management processes, intensive behavioral modules, monitored diet, and pharmacotherapy can be used, devices can be used, surgical options can be instituted, but improvement on person's understanding of a disease is very much important, and that goes down to us understanding and targeting the root cause. We should not be hacking and sitting on the same branch that we are working on. So it's like behaving like a ostrich with head in the sand, or a dog chasing its tail. That's what is a huge problem. There are multiple factors interacting, causing multiple issues that cause these outcomes. This is an amazing slide that I was able to get that shows multiple interacting issues that impact the obesity, and also, for that matter, something called as human diseaseome, wherein the illnesses that plague the human mind may seem random, but there is significant connectivity between what happens to each individual. But we cannot understand it if we don't collect data. We cannot understand it if we don't bring all this together, but end up developing personalized solution, avoiding mass medicine mindset. We need population health to develop processes but can be improved and personalized. Now, we can do this through food by expanding different healthy cooking approaches, recognize foundational importance of social connection, incorporating mindfulness, moving from health to well-being, moving from simple approaches, but to a holistic approach of behavioral change, changing how education is done at a personalized level. I don't want to promote any quote unquote keto diet or this diet, that diet. I want to personalize the solution. I don't want to create another nutritional pyramid that kind of pushes a mass medicine mindset, which kind of causes trouble. We have to understand that nutrition is a personal issue, that each person responds differently depending upon their genetic, hormonal, microbiome, and lifestyle solution. Hence, each one of us is different, and we need to approach it in a personal manner through which we have to figure out and create an active plan that is tailored, lifestyle that is tailored, and long-term maintenance plan that has to be come up with. All these approaches need a comprehensive solution that has to be developed, and unless new leadership does get involved in this, we are doomed. So where are we? What is the future? Is it all doom and gloom? No. Individual doctors, health systems that are innovative have to be the future beacon of healthcare change. COVID has been a teacher as a brute, rude, and obviously very effective teacher, making us think that many things are out there causing our human mortality and morbidity. But we have to understand that metabolic masks and masks are there, vaccines are there. Yes, we want that. But we have to understand that metabolic health matters, but food addiction matters more. Without addressing both metabolic health and food addiction, we are like sitting ducks for the bug of the day, virus of the day, fungus of the day. We have to come up with public health and interventional health that is blended together. We have to come up with disease diagnosis and disease centric but personalized solution. We have to come up with in person and also telehealth solution and group participation. We have to be able to provide these solutions across the state lines and across global level. Healthcare is no more local, it's global. And essentially, these epidemic views that are in the past of drug and vaccine have to include how personalized changes have to be implemented. The healthcare will change from aspiration to achieve things using people, process, and technology. That's what I expect in the post COVID era. And if we are not able to deliver, we are all doomed. The greatest medicine of all is that teaching people how not to need it. And that is the toughest thing a health professional has to do. And as an infection preventionist, I totally buy it. And we cannot solve the problems of current healthcare by the same thinking. So we have a duty to educate the masses. We have a duty to our citizens, our countries, our world. We have to not just know, we must apply. We must not just be willing, we must do it. This applies to healthcare. This applies to our own state of understanding of life, and how we as healthcare professionals live is key. All medicine starts at the personal level, particularly at the health professional's personal level. One must understand what our nutrition does to us. We can maybe hope to help our human beings in removing barriers for them. And hopefully, I did not take too much of your time, but I will be able to answer these questions if you are able to kind of put them on social media or however you might be able to get in touch with me. Thank you very much.